Good day and welcome everyone to another episode of Healthy Doses with Dr. Erica E. Watson. I am your host, Dr. Erica E. Watson, and today we have an engaging conversation about health equity. I am going to introduce a wonderful friend and colleague, researcher, a professional in the field, and we're going to talk a lot. We're going to have some images. And then at the end, we're obviously, as usual, going to have an opportunity for you to ask questions and to contribute comments. I'd like to start us off today with thanks, as usual. And we'll be able to see this on our slides here. So again, I'm Dr. Erica E. Watson. I am a clinical nutritionist. I am an anti-racist educator, and I'm also a community health provider. At the end of our session, there will be information about how to get in touch with me in case you'd like to set up an appointment to talk about your clinical nutrition needs. So let's get started with our slides and our introduction of Dr. Rashelle Litchmore. Hello, Dr. Litchmore. Thank you for joining us today.
Hello, good afternoon. Happy New Year.
Happy New Year. Here we are. So we're going to start off, first of all, thank you to Career Communications Group, Women of Color, Black Engineer of the Year Awards. Thank you for having us. I'd like to give some background about Dr. Litchmore. Excuse me. Dr. Litchmore is an assistant professor of human development at Connecticut College. Her research spans the areas of cultural psychology, education psychology, Black and racialized adolescent identities, and systems transformation. And it's conducted through clinical and theoretical and analytical frameworks, including post-structuralism, critical discursive social psychology, Black feminist theory, and critical race theory. Currently, Dr. Litchmore is conducting research in both the United States and Canada, so way up north, on the experiences of minoritized adolescents in education systems and investigating the racist integration of a magnet school in the state of Connecticut right here. And she's also looking at the systemic changes needed to support students of color. In Canada, she's leading a project on the experiences of Black Canadian neurodivergent learners. And before all of this, she was a senior policy advisor with the government of Ontario in Toronto, Canada, where she supported government decision-making in addressing disparities faced by racialized and Indigenous people in Ontario. So thank you, Dr. Litchmore, for joining us today. Just a side note, Dr. Litchmore and I are both professionals in our field. We are also both friends, and we have lots of these deep, rich conversations. Today, we're going to have a little bit of a flow. The first thing, of course, is to establish what we're talking about today. So we're going to talk about what health equity is. We're going to hear from Dr. Litchmore, hear from me. Hopefully, you'll start sending in your questions and comments, and we'll integrate those as well. And we're also going to talk about why it's so important for us to talk about this in the first place. All right, so Dr. Litchmore, do you want to take this one? What is health equity? And we'll kind of bounce it between us.
Sure. So, typically when thinking about health, we tend to think about it in the context of doctors, hospitals, medical care, which is usually at the very last stage of thinking about health and equity is when you're going in for treatment. But thinking about health equity overall is thinking about what needs to exist in society as well as in the healthcare system to promote equal health outcomes amongst the various populations. And so typically, even though I use the term equal health outcomes, when we're thinking about equity, we're thinking about the actions that need to be taken in order to achieve those health outcomes. So we're thinking about how we can create equity at the front end to achieve equality at the back end or the end. And so when we look at this picture on the slide, I'm sure that many of you are familiar with this depiction of equity. Where in the first slide, we're seeing equality, right? Same treatment. So we're seeing 3 people, 2 of whom are able-bodied, 1 of whom uses a wheelchair. And it's clear that the individual, even though the individual in the wheelchair has access to the same treatment, i.e. the same box that they can stand on to watch the soccer game, it's not leading to an equitable outcome outcome because, of course, that person can't stand on the box. And so, we're seeing that the person who's has a smaller stature, they can see the football game, they can see the soccer game, but their view is not as clear as the taller person who can see well over the fence. And so in the second picture, we see equitable treatment depicted, where the individual that's tallest, they might not receive the same treatment. So there's no equal treatment because it's established that this individual already has privilege, right? Privilege being height in this height and able-bodiedness in this picture. The person with shorter stature, they have tools to enable them to see over the fence in a clear view. And then the person that uses a wheelchair is given a ramp. Is that a ramp, Dr. Watson?
Yes, it's a ramp. Yeah, I think so. Yeah, that's a ramp.
Right. So they're able to actually access the box, like to be on a higher level in order to see the soccer game. So thinking about that in a context of health, what is it that we as governments, policymakers, educators, doctors, city planners, etc., what is it that we need to put in place to ensure that folks who are starting out in an unequal society, the United States is a fundamentally unequal society, what are we putting in place to ensure that people have equal health outcomes?
That's right. Thank you. I wanted to add on to what you were saying about the images. The person in the middle with presumed short stature, or maybe the person is younger, that they historically have not been able to see well, they're up higher. And that, when we're talking about equity, is making sure that that person who has historically experienced the inability to access something now has a little what people might perceive to be extra, so that they can see the full picture, they can have the full experience. And then me as a provider, I noticed that the person who's in the wheelchair is up on the ramp. And although they're not as high as the person in the middle, I think there's a safety mechanism put into place so that the person in the wheelchair does not tip over and have an unsafe situation. So these are part of equity too. Sometimes we need to give a group or a human, an individual, an extra of something to make sure that they have what they need in the moment, and to make up for all of the inequities they've experienced in their lifetime. So thank you. That was a perfect summary. Here are some examples of health inequity, because when we talk about health equity, we cannot talk about health inequity. In the United States, as Dr. Litchmore implied earlier, in the United States, we have a lot of inequities across the board. We have fueled by systemic racism, systemic discrimination, unbalanced policies and expectations, and even laws that are put into place that ultimately block individuals and entire groups from having full access to what they need. And that could be food, it can be water, it can be housing, it can be education, it can be safety. So some examples of health inequity include low income and therefore limited or no health insurance. I just want to stop here because I notice that I even do this. A lot of times nowadays we use the term access, and access can mean so much. So what I try to do is talk about what access means, what it looks like. So for here, instead of saying low income and therefore limited access, I say what the access is. So that's limited or no health insurance, limited or no transportation to appointments, or limited or no ability to have to attend health or nutrition classes. And another example of health inequity is what we call food apartheid zones. I got this terminology from a presenter on a show on Netflix called High on the Hog. And she used the term food apartheid. And I thought, oh my God. So this is to replace the concept of food deserts, where we have usually city urban environments where there is food trapped in fast food restaurants or convenience stores, instead of food that's available from grocery stores that provide produce, or farmers markets, etc. So this concept of food apartheid zone says that it's not the people who are living in the city who go to the fast food restaurants more. It's that there's some system, some policy, or some law, or some redlining, some physical block that prevents the people from living in that area from getting the healthiest foods. Chronic and widespread and disastrous water contamination. I don't know, Dr. Litchmore, when you hear this what comes to mind automatically?
Flint, Michigan. I think that's
Flint.
always the quickest example.
Yeah, we're talking years and years and years of chronic contamination. This is happening in Mississippi as well. And not surprisingly, maybe it's Dr. Litchmore and the communities that are most impacted are Black, brown, and low income. They're getting bad, unsafe, dangerous, potentially deadly water to drink and to use.
Mm-hmm.
Lack of free and reduced cost mental health care, particularly in densely populated Black and brown communities. I have a feeling Dr. Litchmore is going to want to talk a little bit more about this. This is a major inequity. I don't know, when you were growing up, Dr. Litchmore, did
Mm-hmm.
folks talk about going to a therapist or having group therapy or counseling sessions?
Absolutely not. Absolutely not. I
Yeah.
don't think we even had a concept of mental health. And of course, at this point in history, especially post COVID, I think the conversations are a lot more frequent in Black communities. But growing up, I mean, I always knew I wanted to study psychology, and I wasn't sure if I wanted to be a clinician, but I was getting that imagery from cable TV, watching white therapists on TV.
Oh, yes, yes, yes. Oh, wow. I hadn't even thought about that. The representation on TV. You're right.
Mhm.
Same with physicians as well. I
Mhm.
used to see white physicians all the time. I always wanted to be a physician, and I saw white, white, white all the time. Wow. Okay.
Mhm.
Let's see. When I was growing up, I think we had family friends who were in the field of psychology,
Mm,
and I
okay.
didn't apply it to myself necessarily. I didn't think,
Mhm.
oh, maybe I could go see a therapist. Probably till college, I started taking psychology classes and learning, oh, there's such a thing as therapy.
Mhm.
Oh, our families, our Black and brown communities, we can benefit too. And that doesn't necessarily mean that you need to go see a therapist. There are group counseling sessions. There are other ways of healing our mental health and traumas, mental health problems and traumas.
Mhm.
But just something that we don't talk a lot about in Black and brown communities. And then always, go ahead, Dr.
Yeah,
Litchmore.
I just wanted to add to that. And I think the concept of mental health is a tricky space
Yeah.
for Black communities, because I think, a lot of us, a lot of our families, we take pride in our resilience.
Yes.
And
Yes.
so, stating or thinking that one might need support from a mental health professional can be interpreted as a sign of weakness. And then, but then on the, and then there's also like, similar with health care in general or health research, the systematic racism, and exclusion that Black communities or non-white communities face in terms of being diagnosed or misdiagnosed or pathologized in particular ways. And so, attempting to access mainstream mental health services can be as traumatizing as the traumas that you are attempting to address. One of the challenges with individualized mental health supports is that it tends to try to teach strategies of how to manage individual problems, like problems from like the individual's perspective.
Mhm.
When most therapists would agree that it's the social context and society in general that is the issue, right? And so people might learn coping mechanisms, but until the context changes, the context with which people have to live with changes, they're always going to be experiencing, or they're going to continue to experiencing events. They're going to continue to experience events that can continue to re-traumatize them. And then to add on top of that, what is our
Yes, yes.
definition of trauma? Like what, again, given how our communities might view ourselves in relation to resilience, you
Mhm.
know like what one community or one person might consider trauma, somebody else might just say, well, that's just a part of life, like move on.
Right.
So it's a complicated space.
Yeah, I appreciate you mentioning that. So even if you do go in, let's say we go into a therapist, we talk to therapists, they give us strategies about how to better manage our anxiety. Then you
Mhm.
go out into the world and you're repeatedly faced with and dealing with microaggressive behaviors
Exactly.
or micro abuses, chronic systemic racism, or just daily poor neighborhood quality or
Mhm.
dangerous situations all the time, or poor, I'm always going to come back to nutrition, poor nutrition. No matter
Mhm.
how many strategies you have in your box, your bag, your toolbox, as people say, you can't use them we typically can't use them as effectively if you're constantly bombarded with all these stressors on a daily basis.
Absolutely.
Yeah. I'd say another example of health inequity is this overly advertised bad stuff. So fast food restaurants, cigarette and vaping products, alcohol. Where was I recently? I was in an urban setting recently. It was like a transition zone between urban and suburban, which we see a lot of in Connecticut. There's a lot of that here, where it's like urban and then half a block later, suburban, totally different. And there were all these advertisements for different alcohol names. I don't drink, so I can't recall them, but all these new alcoholic beverages, and at the same time, vaping products and cigarette products, just all over the place. And it was striking, I guess, for a person who's just driving through who doesn't have any exposure. It was striking to see the difference between that and then the next neighborhood, which was suburban, where there were advertisements about fresh food, the gym, how to get to the gym, new cars, et cetera, et cetera. So things to think about. These are chronic and daily stressors that directly impact life. And what we're talking about here is life and death. We're also talking about the inability to thrive, which is very scary. When you can't thrive as a human being, it's scary. We'll just leave it at that till we go to the next slide. All right. How about health equity learning in the classroom? You teach about all of this to a degree. I know you teach a lot of courses about behavior and development and psychology, and you can't get away from health equity, of course. It's embedded in everything. So how are you infusing health equity into your learning in the classroom, and maybe how are your students responding or contributing?
I think so the good thing about Connecticut College is that they have a public health pathway. So students typically come to my class having at least a baseline understanding of what health equity, like why study health equity, right? I think in my context in Toronto was a little bit different because Canada has universalized healthcare, or Canada, Ontario, different healthcare systems in different provinces, and so when I was on the board of a community health center targeting Black communities, and we faced a challenge of like talking about, for example, the social determinants of health, because most people defined health equity as, well, everybody has equal access to health insurance, everybody has equal access to the subsidized health care that's provided by the government. And so people found it really hard to understand why racialized communities, Black and Indigenous communities, were experiencing higher percentages of ill health compared to other communities, when in like, I guess technically everyone had access to doctors, so in taking those learnings into my teaching at Connecticut College, I start by talking about the social determinants of health, which I know we're gonna dig into a little bit further today. And then also like thinking about what the health insurance landscape looked like before the Affordable Care Act was introduced in the 2000s. And then thinking about the number of people who remain uninsured or underinsured despite despite legislation that is supposed to provide access to health insurance, and also looking at the fact that the states that have the most uninsured or underinsured people are also the states with the largest proportion of Black communities. Right. So we talk about how systemic racism is intertwined, and the history of racism and exclusion in the United States is intertwined with people's access to health, both from the policy perspective as well as from considerations of the social determinants of health. So thinking about how longstanding economic exclusion leads to higher rates of poverty for Black communities, leading to lower access to like nutritious food, like you talked about food apartheid, and even like the predatory practices of dollar stores, payday loan institutions that target lower socioeconomic status communities, because they know that people don't have transportation to like drive to the closest supermarket that might be like 10 miles out of town. And so they'll pick up canned goods from the dollar store that's in town that is actually overpriced when you think about buying quantity. Like if you have to buy three, if you buy three at the grocery store, it's going to cost less than if you buy one at the dollar store.
One at the dollar store, yes.
So, those are the topics that we think about, the social determinants of health, as well as how health insurance operates in the United States that still excludes, particular segments of the population.
Mm. Do you find that your students want to engage in these conversations, or do you see that they might feel intimidated about getting into?
I think there's a mix. I think most students, they come to Connecticut College. I think a lot of students at Con are very social justice oriented. So they come, expecting to learn about these things. And in my course descriptions, I make sure to state upfront, we're talking about the isms here. We're talking about racism, sexism, ableism, etc. And so there should be no surprises for you. I think the challenge that I face is that in trying to impart this knowledge or share this knowledge or get students to consider how to approach this information, the students in just learning appropriate research skills tend to like fall into like maybe stereotypical representations of communities. So like it's kind of a given, Black and brown communities are always the worst off.
Right.
And so it's easy to state that.
Right.
But can we examine in a deeper way why?
Right.
Or conversely, since it's a PWI, can we examine the ways in which white communities are like why they're better off?
Yes.
And so it's an ongoing challenge that I've had, which is like balancing sharing facts about inequity with the students without reinforcing stereotypes and their pre-existing assumptions about, poverty and exclusion, that doesn't necessarily help in terms of how they move forward in life. It just, again, reinforces that, okay, white privilege exists and thank God I'm not Black.
Yeah, we don't want this. I've started thinking more about how to integrate. Yes, we're going to talk about disparities, and we're going to talk later in the show about how the word disparities, I'd like to change it up a little bit here. Focus less on disparities within the communities and start talking about our strengths within our communities as well. How our history of interdependence and things like birthing circles, where a group of women will physically be around someone while they're giving birth and follow that woman through postpartum stages to support shared language, shared live experiences, paying for goods from within our own community, purchasing, selling goods within our own community. We have all these strengths. We have this rich culture. We have these rich cultural experiences that go way, way, way back. So I'm going to start trying to bring that into my classroom to talk about that, because we fall into, I think as educators and as students, we tend to fall into Black and brown communities are in a bad place and it's terrible. And that is the truth. Yet also, we inherently have all of this beauty and passion and strength and education and culture that we need to highlight as well. So, all right, on that note, we are going to take a quick break. We're going to come back. We're going to talk about social determinants of health. We're going to talk about health disparities and how I'd like to change that word. And we'll get into a deeper conversation about health equity overall. So we will see you in about 60 seconds. Oh, but before we go to break, please, this is a healthy doses learning time. So please make sure to get up, stretch, get a cup of water, get a glass of water if you can. Do something so that you're not just sitting here staring at us. I mean, yes, we are lovely. However, get up and take a health break and come back and we'll see you in about 60 seconds.
Get ready for one of the most trusted communities for STEM in the nation. Career development and impact. Network building and professional development. Celebration of career achievement, prestigious national awards and events. Access to the most influential industries, looking for the best and the brightest. 3 days of impact. It's BEA 38. And it's coming back to Baltimore for the first time in nearly 20 years. You don't want to miss the event of the year for Impact in STEM. The BEA STEM Conference, Becoming Everything You Are, February 15th through the 17th, 2024, at the Baltimore Convention Center. Mark your calendars now. That's February 15th through the 17th, 2024, at the Baltimore Convention Center. For more information, visit www.bea.org. BEA, Becoming Everything You Are.
Welcome back, everyone, to Healthy Doses with Dr. Erica E. Watson. I am Dr. Erica E. Watson. I'm here today with my great friend and colleague, Dr. Rashelle Litchmore. We are talking about health equity. We're going to talk about as much of it as we possibly can in our allotted time. So we're going to keep it moving. We're going to go on to our next topic of disparities. This is my contribution to the field of health. I would really like to see us, perhaps there's already a term out there that replaces disparities. Maybe there is, and I'm just not aware of it. I'd really like to see us stop relying so much on the term, though, and call it for what it is. I'd like for us to rehumanize the term disparity. So I'm going to read directly from here. Adding in the true meaning of what a disparity is when it comes to human life means replacing the term entirely with terms and concepts that speak exactly what's going on. What's really happening is that human beings suffer much more and die much sooner from these imbalances and threats. So I see the disparities concept as imbalances and threats. These are not disparities. Disparities are discrepancies, typically when comparing groups. Whereas it's important to compare groups in order to highlight differences, the truth is that humans who suffer much more and die sooner from these imbalances and threats should not be suffering or dying as a result of systems of oppression. So if you're required to or so inclined to use the term disparities, in this case, so for example, health disparities occur between Black and white female patients with cardiovascular disease, and Black elderly patients died 15% more often. Maybe reframe it and say it as this. In the study of racial disparities of cardiovascular outcomes in older female patients in a certain neighborhood. So now we're not talking about just female patients, we're talking about them in a certain neighborhood. Hypertension, which is high blood pressure, killed 35%. Sorry, I have a mistype there. 15 above 50, 35 here. We're sticking with 35. Killed 35% more Black grandmas than white grandmas. So now we're humanizing, we're making this more human. What are we talking about? Who are we talking about? The Black grandmas in this area enjoyed spoiling their grandchildren, attending community prayer services, and going to each other's houses for dinner. Now we've taken away this kind of paint color disparities, and we're talking about the imbalances and threats that led to the grandma's deaths or the grandma's suffering. So let's try to rehumanize as much as we can when we're talking about health and health equity.
Mm-hmm.
We have a question in the chat. If you'd like to send that through, that'd be great. Dr. Litchmore gave us a little taste of what was to come, which is social determinants of health. So we're going to jump in with this right after we check out this question. We have a question from Tony. We hear a lot about access to healthcare, but what is that really for people who can't afford it? The government gets credit for saying there's access, but what does that really mean? Oh, Dr. Litchmore, do you want to jump in on this, or you want me to jump in?
I'll start and then I'll.
Yeah, we'll do our thing.
So this is one of the challenges. Again, in the United States, based on how the health insurance system is set up. And I remember the debates when they were attempting to pass the Affordable Care Act and all the compromises that had to be made, thinking about a single payer system like in Canada and Ontario in particular, where everyone contributes through their taxes to the healthcare system. So everyone gets a health card, and when you need to go to the doctor, you can go. And there's definitely challenges there, but we're talking about the US right now. Right. And instead of adopting a system like that, the US instead decided to go through private insurers providing, so people can access healthcare through work. if they're not working, and or their income level is under a particular amount, depending on the state that you live in, then you qualify for Medicaid or Medicare.
Medicaid. Yeah, Medicaid. Yep.
Right. But the challenge is there's folks that don't qualify for Medicaid because they're working, but their income means that the type of insurance that if they can access insurance, like through buying into the healthcare market, the price of deductibles are so high that there's almost no point. So you see a lot of people just not going to the doctor, even though they're paying monthly into their health insurance, not going to the doctor because they have to pay out of pocket for the beginning of treatment before their health insurance kicks in. And so it's just, that's the built-in inequity, right? So for folks who are not, again, working a good enough job, that they're first of all, their premiums are affordable, and what's covered under their insurance doesn't require high deductibles before their insurance kicks in. Those people are left out if they're working, and therefore don't qualify for Medicaid. So, it's actually quite depressing, and I think about my privilege, because as an immigrant, I have the privilege of working at an institution that offers actually quite good health insurance options. And I remember making the decision of moving from the middle tier insurance to the top tier insurance because I had some health issues a few years ago. Thinking about, like, again, the privilege that I have based on my income bracket to make that decision. The high deductibles that I avoided just by paying like $10 extra per month my health insurance.
Yes. And you are at an institution where you have, here's the word, access to that type of insurance.
Right.
Well, there's so much to say. Let's talk about social determinants of health, and then we'll spin back around because I think we had another part of the question from Tony to address. And then I have some comments coming in. Dollar store. Okay. Oh, the maid. Okay. Let's talk about social determinants of health. There are several categories. So first of all, social is talking about something that's going on in society. Determinants are things that determine something, so that predict something, or that prove something, or that show something. And then health is health. And health is multifaceted as well. So these social determinants of health are external conditions or factors that affect the health of an individual human being and also full community. And I have several categories listed here. These are courtesy of the National Cancer Institute. There are other categories of social determinants of health, but these are the primary ones I've found. So we're talking about education, employment, and income, health and social policy, wellness and nutrition, race, ethnicity, and gender. We can definitely break those out into separate categories. Healthcare in general. So like Dr. Litchmore was talking about, insurance, and neighborhood and environment. As we look at all of these determinants of health, I want us to keep in mind that an individual human being is directly impacted by all of these at all times on all days, and that large communities are impacted by these as well over the time span, right? So at any given point in your day as a human being, you can, as say a Black woman, walk out and try to get healthcare. Let's say you have to go to an emergency room, and let's just say that the staff there are not trained in working with Black women patients, period. And so they don't have the cultural competence training. They don't have anti-bias, anti-racism training, let's say. So now that person, as a Black woman, as a social determinant of that person's health, those two social determinants of that person's health, that person is now at risk of not getting the best care, possibly, and possibly getting poor care, and or possibly having her concerns rejected, which ultimately leads to poor care. So that's just a tiny, although greatly impactful, but tiny example of how social determinant of health determines how healthy you can be. And it's like Dr. Litchmore said before, we can have a whole bag of strategies about how to stay healthy, how to eat well, et cetera, et cetera. These external conditions and factors, though, have put such an emphasis on your potential outcomes that they can ultimately reframe, redirect, or destroy those potentially healthy outcomes. So there's my take on part of social determinants of health. Dr. Litchmore, what are your thoughts? I know you talked about this directly in class, and this is a part of your research. What are your thoughts about SDOH, as we call them?
SDOH. I think again, when I was working with our community health center, because the framing of them is important. So to your example of Black women attempting to access healthcare, the medical practitioner doesn't have cultural competence training, etc. But we're not even there yet. Like just basic medical training in relation to our skin tone. I recently was reading about again this concept that Black people experience less pain or have a higher pain threshold. So the rumors and stereotypes about that. Thinking about the Tuskegee experiments, et cetera. So and I remember attending a health equity conference and even like training for dermatologists, right? Like understanding how to detect skin conditions on lighter versus darker skin tones. Like this is basic medical training, that a lot of folks are missing before we even get into the, like face-to-face racism. And so all of that is involved in like again the back the end I don't know what the right word is, but
I like the end yeah, the end zone, the end I like the end.
Right, like when you're actually in the doctor's office, but before you get there, this is where again historical factors that impact community health and therefore individual health come into play. And so typically in the work that I've done previously, we made sure to reframe the concept, the social determinant of race, ethnicity, and gender to racism, discrimination, sexism, right? So it is not our race that is, a determinant of ill health, but how we are treated and our historical experiences based on how we've been treated or status in society that leads to particular health outcomes within our communities. And so I actually really like the World Health Organization, their list of the social determinants of health, because they include things like, food insecurity, working life conditions. So, for folks that are working in the Amazon factory, which again, disproportionately Black and brown communities that don't have access to regular breaks, who have to walk miles and miles from one end of the factory to another, one end of the storage facility to another to pick up the toothpaste that you ordered on a whim, and then the blender on the other side for the 2-day delivery.
And then deliver it to a neighborhood, any neighborhood,
right,
with no protection, any neighborhood anyway, you're expected to deliver.
Right. So these are the things, like those kind of working conditions are going to disproportionately affect communities who because of again systemic exclusion are the people most likely to be found in jobs like that, like don't have the education levels, etc., to access like white collar jobs, office jobs, etc. And so again, the social determinants I think is the most important thing to teach about in relation to health equity, because again, a lot of people think about healthcare as what's happening at the end in terms of being in the doctor's office.
Yeah, it's the whole journey. It's your whole life. The end is the doctor's office, perhaps. It's your whole life. We have actually I want to just stop for a second. Thank you for bringing up the WHO's version of SDOH and saying racism, and that by doing that we're taking away the pressure for the person to believe that their Black body is at fault for disease, or we're taking away this illusion that the Black body is at fault. Black people, brown people are not born inherently predisposed to type 2 diabetes. So African Americans, Afro-Caribbeans are not born with this type 2 diabetes gene. And yes, I'm confirming this as a health professional in this field. There's a lot of research here. We're not born with a gene that says, oh, at age 32, Erica Watson is going to develop type 2 diabetes. No, it's a whole mix of all of these processes and all of these systems that destroy our potential for health, that lead into, that funnel into cardiovascular diseases and cardiometabolic disorders like type 2 hypertension and type 2 diabetes. I wanted to make a comment too. I see in the chat here what we're talking about, particularly regarding Black women receiving care, is particularly critical during childbirth. So here's one of my other favorite topics. We may need a whole other show for this,
Yeah.
Dr. Maternal health outcomes. We've got Black and brown women dying, especially Black women dying at a rate of at least 4 times more than white women, at least 4 times more from childbirth associated issues. It could be something as simple as having late in the term, so in your 3rd trimester, diagnosis of hypertension, and then the hypertension is not caught, it's not addressed, and the patient dies because of those hypertension outcomes after she's given birth. We're talking about 3, 4, 5 times higher than white populations. Again, life and death we're talking about here. So thank you, Trini, for bringing that up. And then I noticed that we had another quick question. If we could bring that question up again, that would be great. I'm going to move on to the next section. Okay, let's talk about nutrition. I will do this every single Healthy Doses. I will talk about nutrition because I'm a clinical nutritionist and because nutrition is required of every single human being on the planet. It's not discussable, it's not refutable, it's not arguable. Every single human has to have some kind of caloric and nutritious intake. If you have a G-tube, if you can chew your food, if your food is pureed, it doesn't matter, we have to have food. So nutrition is the process of giving or getting food and safe water needed for growth, development, and reproduction. It's an absolute requirement for understanding human health. So as we move forward talking about and thinking about health equity, I want us to keep in mind that we can always come back to nutrition. So which groups are getting the best nutrition, which groups are getting the worst, and why? That is a key health equity topic always and forever. All right, Dr. Litchmore, let's get into your research a little bit. So when you did whichever part of your research, since you've done so much work, where did you see health equity concerns or concepts pop up? And then we'll just start with that. Where have you seen health equity pop up in your own research, and no matter what capacity?
Okay. So I'll go back to my work with the Taibu Community Health Center in Scarborough, Ontario, because I think that was the most directly related to obviously the concept of health and health equity. And we, again, in talking about like having to explain the social determinants of health to policymakers, in order for people to understand, okay, it's more than just having access to health insurance or health care. But, for us, I think a major thing was neighborhood violence. In Toronto, unfortunately, rates of gun violence disproportionately impact Black communities, as it's very similar to what's happening here in the United States. And so therefore, like what I'm saying right now is highly applicable to the US context as well. And so I'm going to answer both questions at once in terms of health equity and mental health, which is, if you're living in a high poverty area in Toronto, at the time we call them like priority neighborhoods, and because like these neighborhoods were identified by the government as needing like additional supports and resources. And so of course, there's particular challenges that happen within those neighborhoods. Again, lower socioeconomic status means that you're more like, it's easier for underground economies to infiltrate those regions. And when you have underground economies, you're more likely to have incidents of violence and gun violence in particular. And so, we were seeing, again, this disproportionate number of Black youth and Black male youth in particular dying or getting injured through gun violence. And so not only does that impact the young people who are actually engaged directly in the violence, but it impacts the entire neighborhood. People are living in fear. People are not like they're fearful to leave their homes at particular hours of the day. They're fearful of stray bullets. They want to work with the police in order to make their neighborhood safer, but of course police are not the safest institution to rely on at the same time.
Right.
And so we were advocating for including neighborhood violence as similar to what the World Health Organization outlines. So the World Health Organization outlines, for example, all of the socioeconomic factors, but also like structural conflict as a social determinant of health. And so having to deal consistently with the potential threat of violence is extremely draining on mental health. And Dr. Watson, as you know, mental health impacts physical health, right? So increased exposure to cortisol wears and tears on your blood vessels and your organs. And that can lead to like a more speedy development of cardiovascular conditions and other, health challenges. As well as epigenetic changes, right? So, I know this is something that you think about a lot, Dr. Watson.
All day.
But thinking about epigenetics and how particular stressors can turn on or off particular gene expressions that have impacts for the health of you and your unborn child and your child once they're born. So the concept of neighborhood violence, its relationship with ongoing stressors for people in the community, not just the folks that are engaged directly in the violence, and then how that impacts health outcomes is something that we were really trying to push, both in my work at the health center, but also in my capacity as policy advisor with the Ontario government.
Okay, great, thank you. When you notice any of this pop up, how do I say this? How do you personally respond? So, for example, if you're reading literature and you discover something that perhaps one neighborhood it's just in awful condition, and you might know about that neighborhood, or you know somebody from that neighborhood, or you've heard of that neighborhood, how does that impact you personally? How do you respond? Right, exactly. Right. I think about this because I get really I feel sad a lot when I'm doing my research and upset, of course, and also let me put on a cape and go try to save everyone and fix everything. So I wonder, how do you feel?
I think I've moved away from the trying to save and fix everything.
Yes.
And it's partially due to capacity, right? Because I think my automatic inclination, most of the times when I approach my research, I want it to have like practical applicability. Like, I'm not interested in research for the sake of research, even though I understand the importance of research for the sake of research, because that's research that practitioners draw on to implement structural change. But I also would side-eye some folks that do that, because I remember attending a seminar as a graduate student where the researcher that was presenting said, yeah, just throw in something a paragraph at the end that talks about applicability. Like, you don't have to make it a big deal. So like the folks that are into like the theoretical space, like they're not really thinking about whether or not their research is applicable. And so for me, like I do try to balance those two things. But then personally, thinking about like mental health and everything like that, it was starting to wear on me, because I realized like I can't save everybody. And when you're thinking about these structural issues, so for example, my research is primarily in education equity, and recognizing that this study that I've done with 10 students, is that going to impact policy change? Right? Is that going to impact how teachers interact with students in the classroom? Is that going to impact the structural exclusion of students thinking about tracking and streaming, and how that impacts people's long-term outcomes because they don't have access to appropriate education through no fault of their own, right? Through how the system is structured. And then that's going to impact their health outcomes. So, coming to that realization made me like just try to like focus on like the small spaces that I'm in. And to think about like my teaching as hopefully, impacting the students that I teach, who will then become policymakers or doctors or lawyers or, whatever. So I have to think about that in a different way instead of trying to like fix everything myself.
Yeah, I agree. And it's taken me a while to get to that place. I have learned, well, I'm still a provider, so I want to still physically intervene and help as many people as
Yeah.
possible, especially the people who have the highest needs, right? But I have learned that as an educator, like you said, and as an activist and as an advocate, whatever I've learned from my research, my applicable research, I'm going to carry forward to the classroom or whatever setting I'm in. And sometimes that's all we can do. Sometimes it's all we can do. All right, on that note, we are going to take another quick break. We are going to, hopefully on this break, stand up, stretch, get a drink of water, get a drink of something, take a mental break from our discussion. It's okay. And we're going to come right back and we will wrap everything up. If you have questions, please start thinking about them now. Feel free to put them into the chat. And we will see you in about 62 seconds.
What if you could build your own city? A place where every child can find nurturing people to help them achieve their full potential. A place where every adult can access job training support. Where health education is abundant. Where social justice ruled the land. A place without limitations. Welcome. You have arrived at STEM City, USA. It is what every city should be. A safe and trusted community where you find people and resources to help you become everything you are and beyond. STEM City is unlike anything you have ever experienced. It is a digital twin of the world around you, only better. STEM City is about energy and soul renewal. It is more than a digital world. You can almost feel the power of live cultural events, music, and theater. STEM City promises a better future for children with caring mentors and hands-on activities with dedicated tutors to support our youth. STEM City is your passport to a healthy lifestyle with weekly events addressing our community's many issues. STEM City is your financial well-being with helpful information on wealth management, career advancement, job training, and so much more. STEM City is the community you deserve. It is the city where your dreams can come true. STEM City USA, a place in the sky that is accessible to all who reach for the stars.
Welcome back. There we are. Yay, technology. Welcome back to Healthy Doses with Dr. Erica E. Watson. I am Dr. Erica E. Watson. I am blessed and honored today to have my good friend and phenomenal colleague, Dr. Rashelle Litchmore. We are talking today about health equity. We are getting as much in about health equity discussion as we possibly can in our 1 hour. So glad to have you back here to join us. As Dr. Litchmore was talking about before, when we do research, we want it to be applicable. Well, relevant, applicable, usable in some space, in some way, for some group, for some person, for some organization. That's how Dr. Litchmore and I roll anyway. My research was on reducing hypertension in African American women using an anti-inflammatory nutrition protocol. And so everything that I learned, which, by the way, a lot of what I learned is that poor nutrition is driven by systemic racism. Everything that I learned, I tried my best to integrate into my own practice today for all of my patients, regardless of ethnic background, regardless of gender. I have a company called WiseTree Health Connections, and we'll put that information up at the end so that you can reach out to me if you'd like to set up an appointment, and we can talk about your clinical nutrition needs. Here are some ways that we can apply what we've been talking about today, some ways that we can promote health equity. You, as an individual, this is advice for medical and health providers, for mental health providers, nutritionists, and full communities. And I do notice that we have some comments and questions in the chat, and we will definitely get to those. So first, you can research health equity policies and education in your area, then get involved. Dr. Litchmore is a prime example of somebody you could reach out to. I'm not saying that you need to reach out to Dr. Litchmore. However, she does have the resources and the connections in her local community. And so if you're in the area, perhaps you could reach out to Dr. Litchmore and ask her. You can find out more about local farming and agricultural practices in your community. And I do promote plant-based, yes, fungus-based, and seaweed-based eating. Fungus-based means mushrooms, by the way, folks. Eating. And so if we can help to support local local agriculture and farming practices that grow things that we can eat, that grow non-animal things that we can eat, and then bring those practices into communities where you know they need the most nutrition support, doing that helps to reduce health inequities and helps to increase health equity. Medical and health providers, please hear me, please. Please ask for and authentically engage in and contribute to and continue to update training in cultural competence, anti-racism, and anti-bias approaches to care, and empathetic and trauma-informed care. Please, please, please. If you haven't done it, which most folks did not get in med school or other graduate school training, please do it. Medical health providers can also stop blaming Black and Brown patients for what we call non-adherence, which is a term I don't really like, but we use it. For example, missing or being late to appointments and not following culturally irrelevant guidelines. Mental health providers, please research the history of racist and sexist testing in psychiatry and psychology. Nutritionists, please become more familiar with cultural practices. And then in communities, there's a whole host of options in terms of getting involved with faith-based communities and organizations and policy and government and local educational institutions as well. So there's a lot you can do. There's a lot to get involved with health equity. All that being said, let's go just quickly to our chat here. Amazon. Okay, Dr. Litchmore, I don't know if you can see this. There was a question, what do we think about, here we go, large companies such as Amazon moving into the healthcare access space? And then the person said, from what I've seen in trying to secure health support for low-income communities, I think the service could be helpful. Their concern, though, is that social safety nets would use private insurance and then wash their hands. So the main question is having Amazon move into the healthcare access space. I am going to say from my gut, no. If I believe that Amazon were employing really healthy practices across the board for all their employees, I might be more inclined to explore this. But I'm just going to say no. I don't support it. That's what I'm saying. Any thoughts, Dr. Litchmore?
I think I understand the commenter's perspective, which is that it could be helpful given the lack of services that exist in these communities. But we also know that Amazon is a fundamentally exploitative corporation. And so, I think ultimately, I don't know what the ultimate outcome of this addition would be, and including, as the commenter mentioned, the actual government absolving itself of the responsibility of legislating and supporting or providing healthcare access to communities. But unfortunately, that's the trend that we've been seeing in the US, for decades, which is the continued privatization of resources that should be public, at least under or my political perspective. So, whether or not we can, I don't know if we can stop it. I think it's already happening. But I think ultimately it will contribute to a decline in how much, regulatory access the government has in healthcare. So It's a little bit depressing.
It is, which is why I said no.
Yeah.
Yeah, sometimes it just. We have a follow-up question. I realize we're over time a little bit. We have a follow-up question though. When I go to CVS or Walgreens for my vitamins, they're often sold out. I can always get them on Amazon. So this might be a little bit different from, or maybe it's not. Maybe it's a lead into this whole healthcare provision by Amazon.
Yeah.
Perhaps Amazon or similar companies are sneaking in by providing these vitamins when we can't get them. They know we can't get them at CVS. They know we can get them at Amazon. So perhaps that's a way of getting into the healthcare provider scene. Excuse me, the healthcare coverage, the healthcare scene. Perhaps it is. Perhaps it's already happening. I just don't realize it.
And that's the thing. That's the thing. Like, you know, when Amazon, the reason why Amazon is able to operate like this is because Amazon's model is exploitative. You know, like again, my example of people having to walk 2 miles to get the vitamins from one end of the factory and the blender from the other, or you know, the boat that they bought online from the other end, like, you know, like a kayak.
The plastic bags.
Or the plastic bags. You know, and you know, we, you know, like the last couple of years, we, you know, people have been attempting to unionize at Amazon and stuff like that. And even like this 2-day delivery, you know, through Amazon Prime, like we've been socialized into this idea that we can order something online and get it within 2 days. Life doesn't have to be like that. You know, we're used to that convenience now, but there was a time when we were prepared to wait a couple of weeks to get what we ordered online. And so we would physically get up and go to a store if we wanted it right away. That's Amazon is now taking advantage of the shift in culture and is exploiting their workers in the process. So even though we as the consumer can access our vitamins in no time, the folks that are facilitating that speed of access are suffering. And that's why it's a fundamentally like immoral situation.
Yeah, and I might add that Amazon, we here, let's just stick with just the United States. We, those of us who can afford Amazon, we have the ability to purchase on Amazon. So now let's talk about places around the world where they can't afford Amazon. So now we have an imbalance again. Now, so then Rashelle and Erica, we can get vitamin D3, which is the best form of vitamin D3 to take. We can get vitamin D3, but then the folks who are furthest away from the sun, who need vitamin D3, who have low income, they can't get it on Amazon, but we can. It creates a power issue, a global power issue as well. Thank you to whomever brought up Amazon. I think it was Trini. Thank you. This could be a whole other show in itself. And not talking about just Amazon, just exploitive organizations in general. We've done our questions. I think in just debrief, health equity addresses, it talks about making sure that those with the least benefit to health get what they need in order to benefit and to be healthy and to stay alive and to thrive. And we have so many health inequities in this country that we need to talk about them. I believe we need to talk about them in a more forthright manner. So instead of saying health disparities in Black and brown communities, we say racism determines XYZ outcomes, and how can we counter racism in XYZ ways. So health equity is a broad topic. It's something I hope that more folks will talk about in public places like this. I'd like to thank everyone again, Bea, Women of Color, and definitely Dr. Rashelle Litchmore, our expert for the day. I hope, Dr. Litchmore, you'll join me again in the future.
We'd love to.
Okay, good. And then if you would like to contact me to set up an appointment, I believe my information is scrolling here somewhere. I'm at wisetreehealthconnections.com and wisetreehealthconnections@gmail.com. So feel free to reach out and we can set up an appointment to talk about your clinical nutrition needs. Before we go, the last comment is thanks. Thank you all for joining us today. Thank you, Dr. Litchmore, and I look forward to seeing you all in the future. Oh, by the way, we are going to have a session where I'll be cooking live. You guys can join me. Yes, we're going to be doing some vegan and other meals, and we'll also be addressing some other health equity topics, and I will be talking about how to reduce hypertension for yourself and your loved ones. Thank you for joining us. Have a great day.
Get ready for one of the most trusted communities for STEM in the nation. Career development and impact. Network building and professional development. Celebration of career achievement, prestigious national awards and events. Access to the most influential industries, looking for the best and the brightest. 3 days of impact. It's BEA 38, and it's coming back to Baltimore for the first time in nearly 20 years. You don't want to miss the event of the year for impact in STEM. The BEA STEM Conference, Becoming Everything You Are, February 15th through the 17th, 2024, at the Baltimore Convention Center. Mark your calendars now. That's February 15th through the 17th, 2024, at the Baltimore Convention Center. For more information, visit www.bea.org. BEA, Becoming Everything You Are.